Hello, and welcome to Other Voices Online, brought to you by Peninsula Peace and Justice Center. I'm your host, Paul George. Californians have been trying to implement a single-payer healthcare system for nearly 20 years, starting in 1994, when Proposition 186 appeared on our ballots. Initially finding widespread support, the measure failed at the ballot box, with nearly 75% of the voters saying no. What happened? Insurance and medical providers outspent the single-payer campaign by nearly 50-1. And a full disclosure note here, I was a staff member for Proposition 186. Efforts to institute a single-payer plan have continued ever since, up to and including last year, when a single-payer bill in the state legislature was pulled at the last minute because it was coming up just short of the necessary votes. Now the author of last year's bill, Assemblyman Clara of San Jose, is back to try again with a new bill, AB 1690, known as CalCare. And that's tonight's topic. Can California finally achieve this 20-year-long dream? Helping guide us through what's always a complex issue. Healthcare is complex in this country. I'm pleased to welcome three people who are very active in the issue locally here in California. First, I'd like to welcome Dr. HUSSAIN, Assistant Professor of Medicine at Stanford University and a founder of the San Jose chapter of Physicians for a National Health Plan. Welcome, HUSSAIN. Did I get the title right? Health Plan, right?
National, yeah, absolutely. It's fine. It's a Physicians for a National Health Program.
Program.
Thank you. Thank you.
Okay, and welcome. Also, I want to welcome Riley Brann, community organizer for the California Nurses Association. Riley, welcome, and thank you for joining us here. And finally, VICKIE MUELLER, grassroots organizer for the Santa Clara County Single Payer Healthcare Coalition. VICKIE, thank you and welcome. So I want to take a start, since you're from three very different organizations. Why don't each of you just take a minute to explain what your organization does. HUSSAIN, I'll start with you. The title should be pretty self-explanatory, but tell us how you go about your work, maybe.
Absolutely. So thank you so much for having me. What an honor to be with all of you today. The Physicians for a National Health Program is an organization that started in 1987, primarily to highlight the goal of most members of this organization, which is essentially to establish a single-payer healthcare system nationally as well as locally. So each each state has its own chapter. California, we're lucky to have several chapters in different parts of the state, but we all are united by our passion towards a single-payer healthcare system. And I have been involved with them about 4 or 5 years now. I had the pleasure of working very closely with VICKIE and with the Senator Clara last year with the organizing of the AB 1400. So pleased to be here today. Thank you very much for having me.
Great. Thank you again. Riley Brann, how about California Nurses Association? I think people are familiar, but give us the quick thumbnail.
Yeah, absolutely. So yeah, I work for CNA. Thank you again for having me here. The California Nurses Association, we are first and foremost a union of registered nurses across the state of California, and are a part of the National Nurses United, which is the largest nurses union in the country. I'm here to talk about CalCare and single payer today, but our union also is constantly working to make sure that nurses have the protections that they need in the workplace, and are getting working on things like safe staffing ratios and all host of all sorts of other things. But I primarily work in the community organizing department and help run our flagship issue of CalCare.
Great, thank you. And VICKIE, tell us about the Santa Clara County Coalition.
Thank you for having me. Can you hear me?
Yep, sounds good.
Okay. I'm a grassroots organizer, and I've been organizing with the Santa Clara County Single Payer Healthcare Coalition. I know that's a lot. They call it the coalition for short. It's a small grassroots organization. It's been active for about a couple of decades. And right now they're busy writing letters to the editor and op-eds that appear in Bay Area News. They host webinars like this one today, but they do it at including volunteers from local community organizations so they can better understand the healthcare needs of the, that happen right in the heartbeat of our community. And their work is supported by Riley and the good folks over at CNA.
Okay, thank you. And I do want to give a quick shout out to another member of the coalition, the Santa Clara County Coalition. Bob Jung really helped me put together this fine list of guests tonight. So Bob, thanks a lot for all the help with producing this. So let me start with the big picture question before we get into all the nuts and bolts. And that would be to answer the simple question, why do we need single payer healthcare in California? And let me toss this one to our attending physician here, Yusra, Dr. Hussain.
Thank you so much. Honestly, I haven't talked to a physician without having the question is, how can you look your patients in the eye and say that we can't administer this treatment for you because A, you don't have insurance, or that your insurance does not approve it or cover it. Unfortunately, this is a real issue that we are faced with every single day. There are people who don't choose to be sick or don't choose to be ill, yet they have no access to basic healthcare. We're not talking about fancy treatments. So in my humble opinion, and I believe a lot of the folks who are here with me in the panel today agree that healthcare is a human right. You cannot have a civil society that is actually free without having access to very basic amenities, which are healthy water, healthy air, healthy and access to healthcare and food and shelter. So, I mean, those things are really the basic principles of any healthy, free society. And for us to move forward as a free country, as a world nation, we really need to have that at the forefront of our vision, essentially, and ensuring that everybody has access to basic, decent healthcare system. So that's where I stand.
Well, that makes perfect sense. One of the things that's really seared in my memory is from, probably 20 or 30 years ago. I was with my doctor at Kaiser, and I had a developing blood clot in my leg, and she wanted to put me in the hospital, but their guidelines said no. And she was so upset. She's sitting there, throws her pencil down and says, I am not practicing medicine. And it was scary to me as a patient, and I really felt for her as a physician who has certain motivations to help people, and they can't do it because of the bureaucracy and the profit motive. What's our situation in California right now in terms of uninsured? And we must have made some progress with the ACA and stuff, but there's still a lot of people uninsured. And Riley and Vicki, feel free to jump in anytime if you have some stats handy that
I actually kind of a little bit do. Yeah.
Go ahead.
Yeah. And the current state of healthcare right here in California, it's kind of tricky because you can look up numbers and it'll tell you that 3.2 million Californians were uninsured in the year 2022. But then if you did a little bit deeper, you look at, there are people that have insurance, but they can't afford to go to the doctor. So you can look at statistics like 52% report skipping or delaying healthcare due to cost in the past 12 months. And of those that delayed the care, half of them say the condition that they have got worse, due to delaying their, getting seen for whatever their ailment that they have. So, these numbers, if you dig deeper, you find more. The more you look, the more you find. So that's the scary part.
Yeah, that's an interesting point. We're not talking about just the uninsured,
Right.
but the poorly insured. I mean, people who have insurance that don't seek health care, I assume, are doing it because of huge deductibles and huge co-pays and things like that. Is that a right guess?
Yeah, that's right. We need a system put in place that's free at the point of service, because that barrier to care is what's causing so many people so much pain.
And
Yeah, I can also
go ahead.
Yeah, no, I mean,
Uh-oh. What happened to USRA?
Can you hear me?
Oh, okay, you're back now. Okay. We lost
Sorry.
you for a second. That's okay.
Okay, great. I was saying that we are one of the only nations that is actually, our healthcare system is tied to our employment. So people who are unemployed have no access to healthcare. It's unbelievable that is actually people have to find jobs to be able to work, to be able to access doctors. And at the minute that they change their physicians or they change their jobs, they actually have to look for a different provider or a different physician, because oftentimes people end up forced into a different insurance plan, into a different program, or they lose their insurance completely. These are some real issues that we're faced with every single day. As a clinician, the thing that I hate the most is having to figure out, what insurance plan my patient is under, what's covered, what's not covered, how many times I have to make phone calls to the insurance provider to provide necessary services, to explain to them why I need to actually provide these services. Healthcare currently primarily funded 70% by government, yet the most healthcare plans that are available are actually private insurance that are for profit. Their primary goal is to actually make profit for their CEOs and deny services. This is how they look at productivity and how they look at their performances, is how well they perform based on how many services they denied coverage for. And this is one of the actually most frustrating points that I have to deal with every single day of my life, trying to justify basic essential care for my patients.
And justifying it to accountants, basically.
Absolutely. It's justifying to people who actually don't even have a medical degree, having to explain to them why it is important that the service that I'm requesting for my patient needs to be provided.
One of the statistics I came across in doing my research for this, and the ones that Vickie rattled off there, I think we must have been reading from the same document, but one of them said that medical inflation over the last decade or so has been 1.5 times greater than regular inflation. Is that true? And what does that, why is that? Why is the cost of medical care going up greater than the cost of everything else?
So I can take a stab at that.
Sure.
Basically, again, we are dealing with a for-profit system. The goal of this system is so the healthcare system in the United States is a for-profit system, and the goal of it is to make money for the CEOs and basically the stakeholder of these companies.
Yeah.
The goal of it is not to actually provide patient care, adequate access to health, and preventive measures. And so at the end of the day, you are dealing really with, yes, a few companies that run the healthcare system, but these companies, they don't compete on who provides the best care. They compete on who actually can do the most denial of services, or who can actually charge their patients more so that they can make more profit. A lot of times also what we're seeing today, which is really, really unfortunate, and a lot of people don't realize it, is the fact that hospitals, big healthcare systems, are buying small independent physician practices and incorporating them in their big systems. What they do essentially is they start charging the same patients for the same services about 1.5 times what they would have charged them otherwise, what would have the primary care physician would have charged them, because now they are part of a bigger system, and that system charges at a higher rate. This is what's causing the inflation today in our healthcare dollars.
Wow.
Yeah. Absolutely. And this is a problem that unfortunately started during the time of President Trump and had continued under the umbrella of President Biden. So more and more of these, private small practices are losing their business to a bigger institutions and being bought by them. So,
well, is it hard to survive as a private primary care physician outside of these big systems these days?
absolutely. I mean, they are really making it impossible for small practices to continue to survive. The way the insurance companies set up in terms of their reimbursement, in terms of the way they contract with bigger organizations. So doctors haven't really been able to survive on their own. This is an example I'll give you, actually, is one of my colleagues was telling me that his patient, who happened to be a Kaiser patient, he's a psychiatrist, and he was telling me that her doctor told her, I only have 10 minutes for you. You're gonna have to ask me one question. And when she tried to ask him about some side effects of a medication that she's receiving, he told her, sorry, I don't have the time to respond to you because your time is up. I have to go to the next patient. The unfortunate thing is all these systems that are run for profit, the way they maximize profit is by seeing more patients, having their doctors see more patients for a shorter period of time, essentially squeezing the doctors into these like narrow visits, forcing patients to not be able to actually, spend time with their doctors. And at the end of the day, making it harder also for, for doctors to prescribe the necessary treatments, because oftentimes at the end of the day, the profit that the system makes is out of denying services, not because, they're providing good care. No, how many services, how many medications that they don't prescribe, they don't approve. This is how the system end up making money.
Okay, let's talk about AB 1690 and how it's going to fix all of this. And I guess we'll stick with you, Yusra, but again, Riley and Vicki, feel free to jump in anytime. Can we go through the major elements of what will eventually be in the bill? And we need to talk a little bit about how this bill works and the timing of it. But let's talk first about what we anticipate being in the bill when it gets voted on, and how it addresses all these problems that you've just so well outlined.
So I'll take a definitely stab at it, and I'll have Riley explain it some more. I am a huge fan of AB 1690, as I believe it will be shaped after AB 1400, which was the bill that I fought for so hard last couple of years. Essentially, a single-payer healthcare system in the state of California promises to deliver care to all Californians, regardless of their race, their ethnicity, their skin color, their sexual orientation, their age group. You are essentially covered from before birth until death. The single-payer bill offers complete access to healthcare anywhere a patient seeks to access care. There is no premium involved. The cost of the system will be based on a taxation that is gradual, based on a person's income. A lot of it actually will provide a huge benefit, not only to patients, but to employee and employers, because those systems essentially will all provide, all these companies will have access to the same healthcare, regardless of where the patient or the business is. It provides coverage for medical, dental, vision, hearing, long-term care, hospital care. So there is and huge savings to our state, something that we desperately need, as you pointed out earlier. Our dysfunctional, fragmented healthcare system is costing us a huge amount of money, and the single payer bill will provide a huge saving down the road. I'll actually have Riley explain it more because I'm sure you have a lot more to say about it, Riley.
Oh, I mean, yeah, the only thing I would add, and that was great overview, Yusra. We have like a 5-point program that we kind of, or 5 points that we like to talk about when we are talking about what is CalCare, what is, this Medicare for all that we're trying to implement. And the first is, like you pointed out, is universal coverage. So this is for everyone, regardless of race, ethnicity, what you make, sexual orientation, any of those things. It's healthcare for everyone. The next is that it's a single public program. There's only one payer. We get rid of this bureaucratic waste that you were talking about, Yusra, and which is also where we're losing a lot of money. You're talking the question earlier about inflation and why healthcare spending is outpacing everything else. It's this inefficient bureaucratic system that is a patchwork of commercial insurance and public programs. The third point is that it's comprehensive benefits and sort of comprehensive coverage for what you're getting as far as healthcare. So, it's not just what you get through Kaiser or what you would get, if you had Medicare. It includes things like dental and hearing and vision and long-term care, as well as prescription drug costs. There's also,
I was really glad to hear that part in particular, that so much insurance, medical insurance, leaves out our teeth, our eyes.
Yeah, things that you would think are just like naturally a part of your body that your health insurance ought to cover. Yeah, and we like to privatize and move certain things and say this is healthcare, but this isn't. And it's really all at the pursuit of profits, like Yusra has said a couple of times now. It's it's just their way of trying to figure out how they can make another dime out of a dollar off of everyone. And then the few other points I'd like to just make about what is CalCare, what is in this bill. It's really working to create a freedom of choice for patients as well. If you're in an employer-sponsored health coverage plan, like Yusra was saying a few minutes ago, you go see this one doctor in this one area because that's who covers you, right? And as soon as you move insurance plans or move jobs, all of a sudden you have to go to a different person. Under CalCare, you'd be able to go see any provider that you want in the state, and you would just present your singular CalCare card, and you'd get coverage, and you'd get to see the care that you need. And then the two last things I think are really important is just it's free at the point of use, at the point of service, right? There are no premiums, there are no copays, there are no deductibles or bills. I think that's a really important point when talking about what is Medicare for all versus these other answers to our healthcare system. Any plan that creates a cost barrier, which is someone having to pay to receive the care at any level, cannot be a universal program by nature, because there will always be some people who are unable to pay or don't have the ability to pay. So, single payer Medicare for all CalCare is always going to be free at the point of service. And then the last point that I just like to make is a just transition for all of the current workers in our insurance industry. There will be funding set aside. I believe it's like 2 or 3% of the entire budget of the bill is set aside to do things like provide a just transition for these insurance workers to either retire, or go to get new education, or to get placement in the new Medicare for all system. And so this is, we want to make sure that we take care of the workers through any major transformational change that we have in our country.
An important element. So I'm going to guess that a lot of our audience members are going to have some detailed questions about how this works. And I'll leave a lot of that detail up to the audience members and hope they do try to pull this apart and understand it. But let's spend a minute on what's going to be the first obvious question, I think, for a lot of people. How does this get paid for? What are the finances behind this system? What are the economics? If you don't get any kind of bill when you go to see the doctor, who's reimbursing the doctor, and how does that work? And this is where we get to the complex. Yusra, you want to take this one again?
Riley,
I'll go
it's up to
first if
you.
that's okay, and then I'll pass it to you, Sarah. The one thing that I would like to
Sure.
say about this question that I always find so interesting, and it's a valid question, like we ought to talk about it. But the thing that USRA said at the kind of end of her last statement was that, you know, this system will save us money. So when we talk about how is it, you know, how much is it going to cost, we should first start with the framing of this system is going to save us billions of dollars, and will be cheaper than what we currently have, because we get rid of the bureaucratic waste and this patchwork of systems. And, you know, we get rid of all of, I mean, USRA, I'm sure you could tell us the hours of time that you've spent negotiating with insurance agents on the phone about getting coverage for your patients. And we get rid of all of that, which means that we take all of this money that's kind of floating around and not really going towards what we call direct patient care. That money is then able to be reallocated to direct patient care, meaning that more people are going to get more efficient healthcare. And yeah, you know, there's a variety of ways in which we could pay for this system, whether it means repealing the Trump tax cuts, whether that means, you know, lowering some of our budget from the feds for war. I mean, there's any number of ways in which we can actually pay for this. There was a bill last time, I believe, called AC 11 that was a single funding proposal, but there are multiple. But it would be a system of progressive taxation against the rich to essentially fund this system.
Okay, that seems straightforward enough. So, USRA, did you want to add anything to the economic picture?
Absolutely. Thank you, Riley. That's really exactly what, you know, essentially the gist of it. Basically, if you look.
Uh-oh. Froze again here. I've been getting a message that USRA's bandwidth is kind of low, so I think she might be cutting out once in a while. Until she gets back, let's shift this over to our organizers here and ask the question, how are we going to get this passed? We've come close in times before.
Okay, can you hear me now?
Yeah, you're back. Good.
I am so sorry.
That's okay.
Yeah. Okay. Yeah,
we're all used to Zoom.
Unfortunately. Okay. I wanted to highlight a couple of things, honestly, that I think are very important when it comes to financing this type of healthcare system. So for one, we are currently paying about 1/3 of every dollar that's spent on healthcare. This is about 30 cents out of the dollar. In terms of overhead, that is overhead that's not spent on patient care or reimbursements for doctors or nurses or anybody else, but is spent on wasteful type of work that is primarily to deny coverage, to process claims, to you know, do this or that. If you take a look at any major hospital in the United States, I would say a huge workforce of that hospital has to deal with how to process the claims, which insurance this patient has, which insurance that patient has, what this insurance covers and what that insurance covers. A huge part of the work currently is dedicated towards figuring out how the healthcare insurance works. If you take a hospital in Canada, for example, you have the classic example is there are about 6 employees in a major hospital the size of Stanford who will process claims because this is how simple it is, as opposed to an entire floor at Stanford Hospital dedicated to processing claims. This is the difference that we're talking about in terms of just the overhead that to run the healthcare system, the dysfunctional healthcare system that we have today. That's one area of saving. Second area of saving is we're not paying CEOs, you know, any profit at this in a single payer, non-for-profit healthcare system. This is a system that is purely designed as a non-profit system. The goal of it is not to make a profit for the insurance companies. The current healthcare system that we have today in the United States is a for-profit system. The goal of it is to make money for the insurance providers. The third part of it is that, you know, you take actually a lot of the money that currently is spent, even from a program like the Affordable Care Act. Unfortunately, a lot of that money is being funneled again, even though it's a government money, is being funneled into private insurance companies to run the program. It's again wasting the money, breaking it down into pieces, so much goes into, frivolous, unnecessary, spending that could be actually directed towards patient care. So plus you will also, I would argue that a single payer healthcare system is a huge opportunity for us to create jobs for people, a decent type of jobs, because you're going to have 3.2, or depending on the statistics you look at, people entering the healthcare system who currently don't have access to the healthcare system. These people will be needing to care for by nurses, by physicians, by other physical therapists, other allied healthcare. There was going to be a huge demand to creating these jobs, more training for these types of workers. So we are actually going to be creating better jobs, decent jobs, who actually for people that will provide a true type of service to patients as opposed to deny services to patients. So, and into the taxation and the way it's going to work, actually somebody did a calculator, and I could drop the link to that. Actually, the commission that is through California, looking at Health California now, looking at the cost saving in this system, truly a single payer system is the only system that's going to afford, that's going to allow us to actually save money and will be affordable. And the taxation that will be in place will not really raise anyone's cost at the end of the day. Actually, it will save employer at the end of the day a huge amount of money, and will actually, most of the employee will be taking home money that they would have spent otherwise on overheads and for their insurance. So I'll leave it to that.
A very comprehensive explanation. Thank you both. So let's talk about what needs to be done to get this passed, and what's happened in the past that we haven't been able to get this out of Sacramento. What's it going to take in the legislature this year and next year? Because this is what's known as a 2-year bill. It doesn't get actually voted on until next year. Riley or Vicki, you want to take a shot at the organizing aspect of this?
Yeah. Well, just right quick, there's a lot of organizing going on just right now, revving up. In February, Assemblymember Clara introduced his bill, and right now he's working in collaboration with the California Nurses Association and to grow the single payer health care movement and to educate the public. So as we speak right now, Assemblymember Clara is hard at work. He's engaging in meaningful, real dialogue with his new colleagues, because there's a whole lot of new people in the state legislature right now. So this is their first time out, and he's talking to the new state legislator, and he's getting ready to introduce his California Guaranteed Health Care for All Act, and it will be introduced in 2024. But right now he's working just to kind of get them up to speed. So during the coronavirus, when Sacramento, everything was all shut down, some of these big bills didn't get the conversations, didn't get what they deserved. They weren't even discussed well. And so now is the time, and now it's really the chance for him to get his messaging across. And also, like I said, there's a lot of new legislators so right now we're doing a lot of organizing. And I know I've been working with CNA, and we have a petition to get supporters in our area, and we have a CalCare pledge, and I know everybody that joined this Zoom will get an email with the pledge, and you can sign it if you haven't already. So you can show your support for a single payer system, and these pledges will be turned over to Sacramento. I think that's the first stage of what's going on in that CNA has us working on, and Riley can talk more about that too as well.
Yeah. Riley, do you want to add to that? And I know all these organizations represented here have been holding a series of town hall meetings. That's how I came across this idea to do this program this month because you were just doing a bunch of town halls to drum up that popular support out there that it's going to take with our elected leaders. What else is going into trying to get this passed this year, Riley?
Yeah,
Or next year?
That's a great question. And so first off, I would just want to agree with everything that Vickie said. We need to build a movement of people that are calling for this in the legislature. Grassroots organizing will be key to winning CalCare. In addition to that, though, like Vickie was also saying, we're working within the legislature. We're creating relationships with Clara and with his staff, and he is going out and disseminating that into the legislature to build support. We have a 5-point program or 5-point plan that I put into the chat that I hope you're able to share with others. But we kind of listed these things off of as, building the movement for CalCare, broadening and deepening our coalition with other organizations like the ones on this call and even more widely. Building support specifically in the labor movement, that will also be key and essential to us winning. This past year, we've been sending around staff members to tons and tons of different unions that have come to us and requested that we provide some sort of presentation for what CalCare is. And I'm really happy to announce that we've had many of these organizations sign on an endorsement to our campaign and with their member support. So yeah, labor movement is going to be key and essential to doing this, as well as a robust public education plan, right? We talk about building the movement, getting everybody on board, getting people out, disseminating this information so that people know that it's happening and it's in the legislature and that we have a real opportunity to lynch this bill shut and to win it. And then the last thing I'd say, it's just organizing inside the legislature. And so, Paul, you mentioned the town halls that we've been doing with Assemblymember Clara. So this is a huge part of that, is going up and down the state and inviting other legislators at all levels, not just at the Assembly, but at the state Senate, in city councils, right? We can also organize in city councils to create resolutions in support of CalCare to build upward pressure on the state legislature.
There's something people can do in their own hometown without even leaving town, right? Is to get your city council to pass a resolution in support of single payer.
Yeah, absolutely. And many of the big states have already done it. Our big cities have already done it up and down our state. And so there's already templates. And if you're interested in that work, you can absolutely reach out to us, and we'd be happy to point you in the right direction for resources and materials that you can use to get your city council member and city council on board. And enough, upward pressure coming from the ground up is what gets these state assembly members and state senators and beyond to feel emboldened and have that confidence to take the right step forward. So yeah, absolutely. There's tons of different tactics, and we need people to get involved. Another thing that we say all the time is, the public is with us. It's not like we got to go out and we need to, convince or have, millions of persuasive conversations about this is the right thing. If you look at polls and stats, whether they're Democrat or Republican, the majority of people support a Medicare for all single payer type system. And so our job as organizers and activists is to go out and turn that passive support that already exists into active support by bringing them into the movement, by getting them to take action, by making a phone call, posting something online, asking them to join you at an event. All of those things, slowly build up to us turning that passive support that exists into more active support that will eventually win us this bill.
Well, let's get some of those grassroots activists involved in this right now by bringing our audience on for some Q&A. There's a couple of ways you can participate, those of you who are watching from home. What we really like is for you to click on the raise your hand icon down at the bottom, and your mic will be opened up so you can ask a question of our panelists. And so just go ahead and click raise hand. And if you prefer not to talk, there's the Q&A box where you can type in some questions. So I see we have, I'm sorry, I'm probably going to slaughter your name, but withYUSRA. So David, our director, if you could bring him on, and I will just start with quick question from the Q&A box. Where is Mark Berman on this currently? Any known concerns we can help address for him? Any of you know where Berman is on this?
Well, I can jump in just a little bit because I talked to Mark Berman during AB 1400, the bill right before it didn't get a vote. So I was calling, I had him on speed dial pretty much. So I was calling their office and they kind of knew a little bit about who I was. And I've talked to Mark Berman, he's from Texas, and we had a little conversation. He was about ready to, he was talking about the bill, and he said that he was going to sit down and read it. So I got back with him. I said, so did you read the bill? I talked with him, and he said that this is a very important piece of legislation. This is what he told me, and that he needed to make sure, in order to get the right decision, make the right decision and get the right vote, he wanted to look at, how it's going to be financed, and he wanted to look at a bunch of bills and sit down with it and give it the attention that it really deserves. And then I spoke to the office, and the gentleman that I'd spoken to like several times in a row told me that he was going to vote yes on the bill. So I don't know, this new bill isn't out yet, and that's what his office was telling me when, I had several conversations with him, and he's not my assembly member, but we've had a lot of conversations. I don't know why they would change up the bill so much this time that it wouldn't, resemble AB 1400. So I think we're in good shape with Mark.
Okay, good to hear. We'll follow up next year when it's time for letters to Mark. Okay, let's bring on audience member Zima Witlaski, and I hope I have.
Hello, can you hear me?
Yes,
great. Well, thanks for hosting this. I've lived in California for 30 years now. It is the size of a medium-sized European country. And the reason I bring this up is because many countries around the world, in Europe and elsewhere, have some form of, I'm going to say, universal healthcare, for lack of a better term. They really differ from place to place, how they're funded, what is covered, what is not. And I was wondering if you did like a comprehensive study of all this, because some places run into problems, like NHS recently in Great Britain, right? So some systems seem to work better than others. So I was wondering what what the nuts and bolts of all of this would be, how you view this. Thank you.
Okay, thank you for the question. Who wants to take that?
I can take it actually a little, if that's okay.
Sure.
There was a really, can you hear me all?
Yes.
Okay,
Yep.
great. There was a very nice colloquium that was held right before the pandemic in 2019. Stanford, UCSF, and UC Berkeley, where they invited actually a whole bunch of representatives from European countries as well as Canada, England, essentially discussing what a Medicare for all or single-payer healthcare system would look like in the United States. And what I loved about the colloquium, it was actually mostly these countries were encouraging the United States to pursue a single-payer healthcare system like Medicare, and also pointing out pitfalls that we can avoid as a country because this is a new experiment in the United States. I can tell you honestly, one of the major differences between United States single-payer healthcare systems, such as Medicare for all, or what the AB 1690 bill would look like, is that this is primarily, in the United States, is going to be a government-funded nonprofit system, privately run, meaning essentially that the doctors and the healthcare system, like hospitals and clinics and radiology and labs, will continue to operate on a fee-for-service programs or system. So there is going to be continued incentive for doctors and hospitals to continue to provide. We're not going to be employed by the government, and that's actually, I would say, probably the biggest advantage of AB 1690. Sorry, in California at least, and the Medicare for all nationally. That's a huge difference between that and say. the National Health Service in UK or the Canadian system, where the physicians and the hospitals are operated by the government. So I think I just want to throw that as one of the major pitfalls that we can avoid once we start Medicare for All system here in the United States.
Okay, thank you very much.
If I could just add one thing to that, I think that was a brilliant answer. One of the things that I noticed is that I'm sorry, I'm going to mispronounce your last name, but Mr. Lasky said was about the UK system is an example, right? And then sometimes people are saying, oh, this UK system's not doing quite as well. And I think that it's really important to investigate the reason, like why it's not doing so well. And if you look back at their papers and things like that, you can see what's happening in the UK system is that they're slowly selling off pieces of their publicly funded program to private corporations that are looking to make money off of it. And that really does speak to the root of the problem in our healthcare system, which is this incessant need to look for profits and to create profits. And so when you create that ability for individuals, organizations inside of a healthcare system to do that, you see the quick degradation of it.
Okay, thank you. That rounds that out. We've got James online to come on with his mic. So if you'll start bringing him on, David. And we have another one in the Q&A box. This is from Bob for Vickie. How can someone get involved with grassroots support for CalCare? What skills do they need? How much time do they need to commit? And following up, if someone is already active in other issues like housing, wage theft, and climate, how can they leverage those activities to support CalCare? Where did they get started? And that's the gist of what we're talking about here. How do we get this done? So Vickie, you want to take this opportunity?
Of course I do. Yeah. First, I have a little infomercial. Yeah, so we can get started by signing our CalCare petition, and we can put it in the chat, or if you sign up for this, you will receive an email that where you'll get the links. Anyway, you can sign up for the CalCare petition, and you'll receive an email from CNA. What we're doing right now, we're in the first phase of organizing for the new bill, and we'll be what we're doing is we have a little QR code on a flyer, and we're asking people to sign in support of CalCare. So all these and we're just doing some light letting people know what CalCare is, what we just discussed. It's a publicly funded, privately delivered healthcare system that lowers healthcare costs and gives you freedom. So in talking to people, just to share with you guys, out in the streets, gathering petitions, we listen to people in our community and we share. And I just wanted to share with a little bit about what I heard. So the 3 freedoms that are most important to people that I've talked to and we've been talking to in our community is the freedom to, together with their doctor and nurses, take control of their health and their healthcare decisions, the freedom to seek medical attention that's free at the point of service, and freedom to have healthcare that's unattached to employment. So those are the top 3 out of the list of things that we ask them about. We can get involved. You can get involved, first of all, by doing this step. What we also do is we have tabling at different areas. We had one out at the what is it called? With Dolores Huerta. We had she had an event, and we had a table out there. It was the United Farm Workers Union. Yeah, so we were out there and we gathering support. We had tons of support for the petition. If you're bilingual, we really need you. We desperately need your help. And it's easy to get involved. You don't have to have any special skills. If you're attached to another group like wage theft or some of these other groups, that means you have friends that we may have a lot of common interests, but you can talk to your friends there and get that organization to sign in support of CalCare, and that helps out as well. we have rallies and we have, different, we're always coming up with different ideas that we can do. We've had banner drops and all kinds of different things that you can help out. So even if you can't walk door to door, there's always something for you. Thanks
Okay.
for the question.
And let me just mention at this point, all my guests have been putting some things up in the chat, and I encourage you to try to make notes of those. But we will also send an email to everyone who registered for this webinar tonight. We had 60 people sign up, but we'll send out an email with all these links and contact info that my guests have been talking about. So watch for that in your email in the next couple of days. Lots of important links. So let's go to our audience member, James, with your question.
Yes, thank you. I'll be brief. This really gets me, and if I'm wrong, please correct me. We have had single payer since 1965 when Medicare was introduced. We had Part A, Part B. It wasn't Medicare for all because only for the elderly and disabled, and it wasn't first dollar payment because they had the deductibles, et cetera. That system worked and is still in the program, and it works today. So it sounds like single payer is this crazy idea that's coming out of left field, and we already have it. And I think that really should be emphasized. It's been there and it's still there. It just needs to be expanded to all. And it needs to take away the deductibles, the copays, and include things such as the prescriptions, et cetera. That sort of gets to me. Why don't we talk about the fact single payer basically has been there since the start of the Medicare program? Why don't we talk about that?
Very interesting question, James. Who wants to take that one?
Can I chime in? Because I love
Sure.
that. That's a brilliant question. Thank you so much for asking that. Absolutely. Absolutely. This is really what Medicare for All is modeled after. We're going to take a very successful system that we already have in place. We do not need to reinvent the wheel. And we're going to expand it, and we're going to provide better coverage, and we're going to provide services to everybody. There's going to be no discrimination based on age or sex. I mean, frankly, to be honest with you, when Medicare for All, or when Medicare was introduced in 1965, I believe, essentially at the time, there was so much opposition to that, system because they did not want African Americans to be covered. They did not want poor people to be covered. So, fortunately, when Medicare passed, it was actually initially in the spirit of Medicare was to roll to all age groups, to all segments of society. They started with the 65 and older, but unfortunately, the healthcare industry managed to put many roadblocks in its way, and we ended up only with Medicare that we know of today, which is only for 65 and older. But the idea is, for sure, is essentially we take a successful system and we expand it and we build on it.
Okay, thank you. And thanks again for the question. I don't see anybody with their hands up yet. There had been a hand up and I missed it. I think it was from Megan. So if you want to try again, anyway, the queue is wide open. There's Megan. David, if you can bring Megan on, I'll quickly ask another one from the Q&A box. It disappeared. So, I guess Riley typed a question, typed an answer for him. It was about another bill in the legislature right now, but let's not go there right now. Megan, if you will unmute.
Sure, I'm on the CalCare, but I'll ask really quickly.
Go ahead.
Yeah, I'm a delegate right now for the Dem Party, and I just in to follow up on what you were sharing about Mark Berman, that was really helpful. So I think my question's mostly been answered, but I think there's a group of us as delegates that would want to approach him just to really solidify his support and see if we can play a role in that, since we're in his district. So if there were any thoughts you had on what worked to reach him around, I think you said that the financial piece were the concerns. It sounds like he didn't really follow through in saying why he was a yes vote. But yeah, if there's any further thoughts on how to get Assemblymember Berman's support, that would be where I'd want to focus, something I think I could try to help with.
Okay, thank you for a good question.
Yeah, thank you so much for offering that. Well, the first thing that I would say is please do get involved in our campaign for CalCare because we would love to connect you with other district leaders and activists and volunteers who are doing some of this work on the ground. And then also, in addition to that, we could help. We come January when the bill is introduced, we're going to move into phase 3 of the campaign. We're currently in phase 1, moving to phase 2 soon. And phase 3 is going to be essentially working to get the legislators, on board by holding these legislative visits, by doing direct volunteer nurse contact with the assembly and members of the state senate. And so we would love to have you and love to connect you with the resources of the campaign.
Okay, thanks. And we've got another questioner, Bob, in the queue. So David, if you'll get him set up. Another one from the Q&A box from Alfredo says, we already have a shortage of healthcare workers. In fact, many have left the Bay Area due to the high cost of living. Have you addressed this issue or tackled this issue? I believe USRA noted how this will increase the number of jobs in healthcare because it will increase the number of patients. But at the same time, I think we do have a healthcare worker shortage.
Yeah, well, I mean, part of the problem, honestly, again, if you look at how the healthcare, how dysfunctional our healthcare system right now is, you take a system like, I mean, it's not just dysfunctional, it's discriminatory. It actually is racist. We have very low reimbursement for low income, for physicians who take care of low income patients, such as patients who are on Medi-Cal. And for that purpose, we actually don't have enough providers who actually want to sign up with Medi-Cal, for example, or the ACA, which is a huge, again, supposed to be a program that, many of us, I actually signed up as a patient under ACA initially when it first introduced, but I got very quickly frustrated by the fact that, even though I was paying very high premium, no doctor would see me or see my family. So currently we have an imbalance. We have an imbalance where in certain affluent areas, you have an overflow of providers, of healthcare workers, and then you have areas where there is a huge shortage of providers and healthcare workers because of lack of reimbursement. And unfortunately, again, you see a lot of hospitals are being closed because they don't make end meets. And a lot of hospitals, again, in affluent areas are just sprunging, and because they can, capitalize on the, insurance companies. Under a single payer healthcare system, actually, this scenario will be flipped. Essentially, more resources will be directed towards areas that are, underserved, patients who actually really have more health issues, and these hospitals who will provide, and those doctors who will provide for complex patients who have many factors, socioeconomics or others that really affects their health. These people will be provided and reimbursed at a much higher rate. So you will see actually more willingness among physicians and practitioners to go into these areas, to practice medicine in those areas, because the reimbursement rate will be a lot, more proportional to the care that's needed, to the complex care that's needed for these individuals. And I'm hoping this will actually really switch the balance and will attract more nurses and doctors and therapists to go into this field. And I just also want to answer one of the questions in the chat about would this system cover mental health? Absolutely. Single payer healthcare system, mental health is forefront in terms of coverage. So
thank you. Good question. And the honor of the last question will go to Bob.
Yeah, I just want to comment on Megan. Megan, get in touch with us in the coalition with Vickie or myself. We did meet with Mark Berman's legislative director before AB 1400 was supposed to be voted on, but they pulled the vote. And so we actually had quite a broad spectrum of people from Democratic clubs and party, Democratic delegates, the coalition, CNA, unions, labor council people, and we met with his legislative director. And she told us later on that Berman was going to vote yes on AB 1400. Didn't vote, so we don't know for sure, but that's what she claimed. So we think we made some progress. We did put the pressure on by having a broad scope of people meet with Ellen Green, who was and so we can follow up with you if you want to know more about the history of what we've done and who we talked to.
Great. I love it when stuff like this happens. So we are at the end of our time. Give each of you 20 or 30 seconds for a closing thought. Yusra?
Sure. I just want to say thank you so much for having us. This is really a fantastic opportunity. I want to make sure that anybody who actually wants to advocate for a single payer and feels like you need a doctor to actually be behind you to say why this is such a good thing, please feel free to reach out to us. I trust that, Paul, you're going to share our contact information. I would love to connect with anybody who's interested, and I will be behind you in supporting you towards with your legislators, you know, when you're pushing for a single payer healthcare system.
We certainly will be telling people how to get in touch, because that's why I wanted to do this tonight, was to get some activists involved in this. So Vicki, closing thought?
Yes, thank you for having me. This is an important discussion. Also, I wanted to invite everybody here tonight to join us on Saturday, September the 9th at the MLK Library in San Jose. We'll be screening the documentary film, Healing Us, and make sure you see it, because you're going to see a whole lot of people you know in the Bay Area. Doors are going to open at 1:30. It's free, and you will get a link in your email.
Yep.
So look for the link.
Absolutely. That screening will be included in the follow-up email. And Riley, closing thoughts.
Yeah, just in the same vein, thank you so much for having us and having this discussion. I hope everybody joins the California Nurses Association. In just 2 days, we're going to be doing our statewide CalCare call, where we'll go into much more depth of all the work we have been doing and will be doing. And yeah, please join us, right? We're not going to win without everyone getting involved and building the grassroots movement. So please do, you know, get involved, make a phone call, do something, and that will help us take one more step. So thank you.
Thank you. Riley, that CalCare call is open to the public?
Absolutely.
So
yep, I'll make sure you have a link.
Make sure I've got that info, and I'll get it out before that meeting. Well, once again, thank you to all three of you. I hope we've educated a lot of people, and better than that, inspired a lot of people to get involved in this campaign. Keep up the good work, and thank you for joining us here. Thank you all watching at home for joining us and taking the time to be with us. And we will be back next month with other voices. So long.
Thank you.
So long.
So long.
See you then.